Continuing with Module 2, we're going to look at lower gastrointestinal disorders. This is going to cover inflammatory bowel disease, or IBD. We're going to look at obstructions, as well as diverticulitis, ostomy types of surgery. So a variety of things are going to be covered under lower gastrointestinal disorders. So inflammatory bowel disease, or IBD, don't confuse this with IBS. IBD is an umbrella term essentially for Crohn's disease and ulcerative colitis. Both are autoimmune disorders. So essentially the body's attacking itself. One of the big things associated with this is an abnormal response to normal intestinal bacteria. So the body thinks that intestinal bacteria is essentially a foreign object or a foreign substance, and so it must attack that. So with Crohn's disease and ulcerative colitis, they attack a couple of different things. So Crohn's disease, inflammation and irritation anywhere along the digestive tract from gum to bum, essentially. Small intestine and the beginning of the large intestine are the most common areas. It also tends to be scattered throughout as far as what areas are irritated. Ulcerative colitis, what it is actually in the name. Inflammation and sores on the inner lining of the large intestine. It likes to attack the descending or the sigmoid colon the most. But essentially, you have inflammation and ulcerations occurring in the large intestine. Peak incidence, this tends to occur in late teenage to your 20s, so your young adults, as well as later on in life. The majority of it is earlier, though. We do not know the cause as of yet. We've been looking at a lot of genetics. There's a lot of research associated with that. They've identified a couple of different genes. For instance, the NOD2 gene on chromosome 16 regulates intracellular immune responses to bacterial products. IBD3 on chromosome 6 and IBD5 gene on chromosome 5 they're looking at in different types of genes that are getting mutated. So genetic predisposition, if both parents have one of these, for instance, if they have Crohn's, it's a 50% chance that the child will have Crohn's as well. Low fiber diet, so the genetic influence for instance, in the United States, we tend to have more of a low fiber diet, which can actually predispose somebody for having IBD. Stress and other autoimmune disorders may predispose. If you have another autoimmune disorder, you're more likely to have another one. Anxiety and depression does not predispose. It may help with the irritation of the flare-up, but it does not mean just because you have anxiety and depression that you're going to get inflammatory bowel disease. We're going to start off essentially with a snapshot of what Crohn's disease is and ulcerative colitis in chart form, and then we're going to break that down a little bit more in some of the subsequent PowerPoint slides here. So going down with this, location, we've talked about this. Crohn's, anywhere in the digestive tract, gum to bum, ulcerative colitis, large intestine, or the colon, specific to descending colon to the rectum. Depth of involvement. With Crohn's, it's the entire tissue. So from that inner lining all the way out to the outside. So all layers, entire thickness. Whereas ulcerative colitis, you're infecting essentially you're irritating and ulcerating away that first layer, your mucosa, but then also the submucosa layer. Diarrhea, cramping, pain, both can have it. Crohn's disease, it may be less severe. Ulcerative colitis can be severe. It depends on what they're eating as well and what causes that irritation. Bleeding tends to be more specific to ulcerative colitis. You can have some with Crohn's disease, but remember with ulcerative colitis, we're essentially eroding away layers, and just like with peptic ulcer disease, that can predispose you to having bleeding. And in this case, it's going to be bright red blood because we're talking about the large intestine. The blood does not have time to sit, coagulate, and become darker due to exposure to oxygen. Malabsorption issues, Crohn's disease can have a lot of that, especially if we're dealing with the small intestine. Sometimes treatments for Crohn's could be the removal of parts of that, which definitely can increase malabsorption issues. Fistula and strictures. We'll talk a little bit more about that in a moment. Very common in Crohn's disease. Whereas ulcerative colitis, it's rare because ulcerative colitis, we don't go all the way through the tissue thickness. We're only doing the first 2 layers. Rectal involvement, Crohn's can have a lot of rectal involvement and tends to have fistulas in that area, whereas UC may not even have that involved. Can we cure it or successful of cure with surgery? No, we cannot cure Crohn's disease. We can remove parts, but it's not going to cure because it can happen again in another location, whereas ulcerative colitis, it's contained in the colon. If we remove the colon, then essentially we've cured them of the autoimmune disease. So Crohn's disease, usually adolescent to young adult, subacute and chronic inflammation, exacerbations and remissions, transmural, so that is the entire tissue thickness, what we were just talking about. When you have Crohn's disease, you're going to have thickening of that mucosal lining, but also edema, and it can be swollen to the point where you can actually have a blockage. Just think about swelling, you're narrowing that lumen sometimes to the point where you have a blockage. Fistulas and abscesses. So just to kind of go to the next slide and show you what do these look like. So an abscess, essentially you have a tract going through the tissue layers, but then you have a consolidation, a little pocket essentially of infection. Abscess, usually pus is inside of there. Whereas a fistula, essentially you're having, it kind of creates a tunnel. It can be from one part of the intestine to the other, or you can actually have what we call an enterocutaneous fistula, which is an opening between the small intestine and the skin itself. One of the main examples of Crohn's disease that I know of is several years ago, meaning me and my students, took care of a nurse who had had Crohn's disease for multiple years at this point. And one way that she knew she was having a flare-up for it is that she had a fistula to essentially where she was having fecal matter come out when she was urinating. And so she had a UTI to start out with. When we saw her, that had become a very large wound, essentially. And she was in for wound care, and she actually had a ostomy, which we'll talk about later, because she didn't want to have fecal matter get into that wound and perpetuate that infection. Signs and symptoms: abdominal tenderness, spasms, can have crampy pain with meals. Eating stimulates intestinal peristalsis and will essentially perpetuate all of that abdominal pain. So what the patient will do is they won't want to eat because of those cramping pains. And so then you can have malnutrition, weight loss, anorexia. So those signs and symptoms: abdominal tenderness, increased bowel sounds, weight loss, anorexia, nausea, vomiting, and diarrhea. And the diarrhea is not relieved with having multiple bowel movements, malnutrition, malabsorption going on here. They can have secondary infections from scarred or fibrotic tissue. You can have strictures, which is the narrowing, which essentially is what you see here, as well as the abscesses. And depending where your fistula is, you can also have infections. So a lot of the complications of the exacerbation can cause issues with Crohn's disease. Ulcerative colitis can also have systemic complications, which can lead to a high mortality rate. Pathophysiology, remember, first 2 layers, that inside mucosal layer, and then right underneath of that of the colon and the rectum. So you're having swelling, irritation, swelling, and ulcerations. You're going to have blood associated with this. Signs and symptoms: a lot of diarrhea, 10 to 20 bloody liquid stools per day. So losing a lot of fluid, they are at risk for dehydration and hypovolemic shock. Both Crohn's disease and ulcerative colitis can have a risk for that. Rectal bleeding, bright red blood associated with this. They can have weight loss, passage of mucus and pus as well. Crampy bowel pain, like they need to have a bowel movement. Electrolyte imbalances can occur as well with this, and they can have anemia. So they can have decreased hemoglobin hematocrit related to significant blood loss for this. So just to give you an idea of pictures, again, you have the normal colon versus the colon that's ulcerated. So the right-hand side is your normal colon if you're looking at the bottom pictures. This is through a colonoscopy, whereas you can actually see the irritation and the ulcerations associated with ulcerative colitis. And what will happen with ulcerative colitis, the bowel will eventually narrow, shorten, and thicken. You can actually have muscular hypertrophy. So a lot of issues can happen with both Crohn's and ulcerative colitis. Now we're going to look at treatment together. So this is for both ulcerative colitis and Crohn's. Bowel rest. Stop perpetuating the problem. If you continue to let them use the GI tract, you're going to continue to have issues, which is just going to further potentiate the problem that's going on. Control inflammation. This can be done through bowel rest, but also through pharmacology, which we'll talk about in a moment. Reduce number of exacerbations, knowing what are triggers, but then also some of our new pharmacological medications will decrease the number of exacerbations. If you have infection issues, they need to be addressed. Look at nutrition and electrolyte issues and fix them. Compliance with medical regimen. There we go. Any symptoms, discomfort, pain, nausea, vomiting, we need to take care of those, provide symptom relief, improve quality of life. And that's why sometimes people will go on different types of medications that may have a lot of risk associated with them, but the benefits of the quality of life may outweigh the risk associated with those types of medications. So, nutrition therapy goals. We want adequate nutrition and prevent or correct malnutrition issues. Prevent weight loss. Well, a lot of daily weights associated with this. Monitoring intake and output. Monitoring your labs and correcting any electrolyte imbalances. High protein, high calorie diet, because we want them to recover from this. And remember, in order to heal, you do need a lot of protein associated with that. Eventually, we do want them to start oral. We don't want them to remain NPO forever. If they do need to go for long term, we need to look at TPN or total parenteral nutrition. But if we can start anything by mouth, we want to initiate that. Irritants to avoid. So we want to make sure that we're looking at things that will increase peristalsis, and we want to avoid those things. So, for instance, smoking will increase peristalsis. Dairy can potentiate diarrhea, especially with lactose intolerance. Cold foods increase peristalsis, and carbohydrates can also increase diarrhea. Low fiber helps with narrowing in strictures. High fiber can actually increase blockage. So you do have to look at what would be better for them. High fiber, if they don't have a lot of strictures, that's actually what we want them to do. We want to bulk up a little bit there. So, did that backwards. You don't want high fiber foods because of the bulking, because we don't want them to have a blockage. So here's one instance where low fiber is okay. Increased peristalsis, we don't want to do that. So don't, for instance, give them a medication like Reglan, which is going to potentiate peristalsis. So making sure you're looking at avoiding things that are going to increase that motility. Rest and nutrition, skin care to the perianal area, things such as barrier ointments and witch hazel, which is actually further down on this slide. The next slide, we're going to talk about medications, action and side effects. They need to understand when to seek medical care. How do they know that an exacerbation is going on? Stress reduction. Do they have a support system? How do they try to reduce stress? Evaluations of that, better ways to reduce stress, establish a therapeutic relationship to be able to have these different types of discussions, clustering care. These people are losing a lot of fluid. Multiple diarrhea episodes will cause exhaustion. They need rest periods, so grouping things, clustering care, having, for instance, can I have multiple people come in at one time to do one thing versus going in every 5 seconds for that. Pharmacological therapy. So one of the first times you're going to use an antidiarrheal or an antiperistaltic, because we want to slow down peristalsis. So you're going to have that antidiarrhea type of medication for that. Aminosalicylates help with moderate and mild inflammation. What essentially we have here is they act rapidly and have a higher safety profile than second-line agents, initially reducing symptoms. They're not really for maintaining remission, but they have anti-inflammatory properties. So decrease inflammation at the intestinal wall. Looking at corticosteroids, hydrocortisone, prednisone, we have these for a short period of time due to the potential side effects of long-term use of corticosteroids, one of those being osteoporosis, which can then cause breaking of the bones and other types of side effects. This is used to treat severe disease, are on for short periods of time, then tapered off for that. More intense symptoms or your mild agents did not work can put IBD into remission, but is a short-term treatment for an acute flare-up. So in addition to bone loss, steroids cause skin fragility, cataracts, weight gain, mood swings, and also can cause any fistulas or any abscesses. It's going to take longer for them to heal. Immunomodulators, so essentially now we're suppressing the immune response, because remember, this is an autoimmune disease. This is used for severe disease or a maintenance regimen to prevent recurrence. So immunomodulators such as methotrexate, not for induction of treatment. It usually takes about 3 months for onset of action, extended time between relapses or exacerbations. You have an infection risk, and of course the other side effects, because essentially it's a chemotherapy agent. You do have biological treatment as well, which is very expensive, and again, the infection risk can be high. We're still under the immunosuppressives and biologics here. You have something called tumor necrosis factor inhibitors, which is your Remicade. You may see commercials for that. Decrease acute symptoms in maintenance treatment, because TNF is an inflammatory protein, so we're inhibiting that, just to give you an example there. So, surgical options. If all of that medication and everything fails, then we need to take a look at surgery. So intractable disease, we may have to fix complications that occur. So drain an abscess. Remember, that's a pocket of infection. Correct a fistula. So for instance, we don't have a fistula going from the intestine to the outside all the way through. Perforation, obstruction, unresponsiveness to conservative therapy. Poor quality of life. Just to give you some stats, with Crohn's, 3/4 or 75% will have surgery within 10 years of diagnosis. And remember, surgery is not going to cure. They can have a recurrence. They will have a recurrence. Whereas ulcerative colitis, 25% will have total colectomies, and removal of that colon is considered to be a cure. So just to go over a few of the surgical options, small bowel resection, a lot of times, remember, this is with your Crohn's, not with your UC. A patient can tolerate up to 50% removal of the small bowel, but you also got to remember they're going to have malabsorption issues, because that's where a lot of your nutritional absorption occurs, is in the small intestine. We do offer intestinal transplant. It is a newer treatment option for those who have lost intestinal function secondary to disease. Total colectomy with ileostomy, which we'll talk about further with ostomies. And then a continent ileostomy is what you actually see in the picture there. So you create essentially a reservoir, so there's no need for an external bag. They still have a stoma, but you access it with a catheter to drain out the essential fecal matter, which will be essentially liquid. That's why a catheter will work right there. Restorative proctocolectomy with ileal pouch and anastomosis if the rectum can be preserved. So here you actually see they take part of the small intestine. This is what we call a J pouch. And they create a pouch essentially for the fecal matter to stay in. You still have your anal sphincter, and this makes it so someone who had this type of surgery can still have a bowel movement just like a normal person, because that part of the small intestine will actually start acting more like a large intestine. It's amazing what the body can do associated with that.